So this is a patient who's got some arthritis in the big toe is here, and this is the big toe joint that's here. Normally you're supposed to have nice gray spaces as you have here. Hers is essentially almost gone. Has some spurring here. On the side picture here, she has a lot of arthritis here at the top. Normally you don't have that. This is another patient. She has a lot of spurring here. He's got good heel spurs here, and the same thing. She has the same thing on the other side. This is a patient that is well controlled with orthotics. She's pain-free with her orthotics. She might need to come in every few years, get a new pair of orthotics or get them recovered, but otherwise she's doing very well. Here's an example of someone who had implants put in. These two pieces here are originally designed to prevent bone from overgrowing it. It doesn't work all that well with time. They have a lot of spurring on the side, spurring back here, even spurring on the sides over here too. These types of implants generally have a lot of swelling to it. You can develop cysts because of this. And usually if you take them out, what I do is I take them out and I'll just pack this bone here, pack this in with some cadaveric bone. It comes in a little syringe. You just pack it in there, and what you're able to do is just maintain a little bit of stability to that. Here's another example. This is a patient who wanted to have a one-and-done type of procedure. She had arthritis. She said, okay, I want to go ahead and just get it done. I don't want to be going back, getting it cleaned up, and then fusing it, so she wanted to get it fused right away. So she went ahead and we did a fusion, put one screw across, and then put a plate up on top. She was healing pretty well. About 6 to 8 weeks after surgery, got her out of her boot. She bent down to get something. She felt the pop. All these screws over here came out. So what happened is took everything out and refused her with 2 extra screws, kept her in her boot for an extra 4 weeks on top of that. So she's almost 3 months in her boot, and she ended up healing okay. Ganglions, these are very common to see. They are a collection of fluid. They can happen anywhere in the foot, whether it's from a joint or from a tendon. Sometimes they call them a Bible cyst, because the Bible is the biggest book that you have. You just drop it and it pops. Sometimes these cysts are very soft, like a water balloon. If they are, those are a lot easier to drain the fluid out of there and put some cortisone in. If you notice that the ganglion is harder, almost like feels like a pea or a frozen corn, those are ones that are a little bit tougher. I usually don't try and get any fluid out because I don't get any out, and those are the ones either you have to deal with them, or my recommendation would be is to take them out. In the summertime, ganglions usually don't bother patients because they're either barefoot or they're wearing flip-flops, and they can usually deal with it. When the fall and the winter comes by, they generally come in and say, I need this ganglion to get taken out, and that's the way I usually recommend doing it. Ganglions can have a high chance of coming back. I usually tell patients about a 50-50 chance where they can come back. So, bunions and hammertoes, these can occur at any age. If you have them when you are younger, if you do have some kind of surgery done, you're more apt to have some more done later on. Your chance of recurrence is higher the younger you are that you have them. That can be attributed to family history. It can be attributed to narrow and pointed shoes. If, for example, if you had some kind of injury, yes, they can come from that too. What I also have seen in diabetics that have lost their second toe actually acts as a spacer between their first and their third toes. So what happens is because the big toe doesn't have the second toe to hold it in place, the big toe just drifts over and starts butting up against the third toe. Most commonly, you have your second toe can override your big toe. I've even seen patients where the big toe sits underneath the second and the third toe. So those are pretty significant deformities. They can be treated conservatively. A lot of times it's just shoe gear, shoe modifications. When you get to a certain point, there's really no other option to do if you've already tried shoes. Some people say orthotics might help out. I will try orthotics in kids first, but not always. But a lot of times once a bunion starts forming, doesn't matter what you do, it's going to keep on progressing and progressing. Yes, there will be a point to where it stops, but usually it's pretty far down the line. Most of them do require surgery. If, for example, if you have a patient that is elderly, poor circulation, not a surgical candidate, you can always make them some splints or some shields. Those sometimes do help, but at that point it's just a matter of trying to control their pain level. People ask me, so when should I get my bunion fixed? I usually tell them when it's painful, when it's affecting what you want to do on a daily basis, if it's slowing you down, if you tried a number of different shoes, even wider shoes, and it's not helping, that's when I would recommend contemplating on surgery. be a number of different ways to go ahead and do the surgery. It could be anywhere from cutting the bone and repositioning, holding it with the screw, or you can go as far back as actually removing one of the joints, fusing that joint, and that way it will not come back anytime soon. The other thing you can do is put a piece that's called a tightrope, where you put a button on one side, button on the other side, and you use surgical wire, and you just kind of bring the two bones together. That works pretty well. I've had some issues with one of the bones breaking, so I really reserve it for patients that I think would benefit from that. I don't put them in everyone. Healing can be delayed by infection. Anytime you make a cut in the skin, you run the risk of an infection. Even though I do give you an antibiotic before I start, it's not going to make it a 0% chance of infection. It's always possible. Most infections are just within the skin. I have seen some infections from other places, other lectures that I've attended, to where the infection actually gets down into the bone, and you got to clean up the bone, and it's a very long, delayed recovery period from it. Patients with diabetes, if your diabetes is not under good control, so if, for example, your blood sugar constantly in the 200 to 250 range, that's way too high. If it's in the 160, 180, could be better, but I would like them around like 120, 100, somewhere in that range. Post-op trauma or non-compliance, people are walking around the day after surgery, or they're out, young person's out clubbing the day after. I would expect a problem the next day. So here's a typical bunion. Here's a bunion over here. Normally this toe should be sitting straighter, but it's pushing over, and it's pushing up against the other toes over here. Here's another patient, pretty large bunion, pretty large gap between these two bones here. This specific patient had a lot of flexibility in his foot, so even though he's young, I decided to do a combination of things. One of them was to fuse this joint back here to limit the chance of these bones spreading apart again. The other one is here. Here's the two little buttons with the mini tightrope, and that just brought the two bones together. And then also in his case, the fact that his toe angled out over here made a cut in the bone to straighten it out a little bit better. Here's a less aggressive type of bunion procedure. A little bit of a bump here, a little curvature of the toe, but for the most part not too bad. So this is a typical bunion that you can fix by making a cut, shaving the bump off here, making a cut, and here's a little screw holding it together. These two little bones are in the position that they need to be. Hammertoes. Second toe over here doesn't look too bad on the top picture, but on the side picture it comes up and then comes back down. So you can imagine wearing shoes, rubbing on top of the toe, and also there's a knot on the inside of the shoe. So the way you generally take care of this is you remove this part of the bone here. You also sometimes need to do some work in terms of releasing some ligaments and tendons at the joint over here. These, a lot of times, especially in her case, went ahead and put a pin in all the way straight down into the bone to help maintain the alignment. And as you can see here, the pin almost looks like it's sitting farther down. I did that on purpose because as soon as the pin comes out, the toe sits up a little bit and it lines up with the rest of the toes. Neuromas, they are very common to have. They generally affect the front part of your foot. Most common areas is between the third and the fourth toes. Some patients describe this as walking on a marble. So my sock is bunching up. Usually activity makes it worse. If they rest, spend some time off their feet, and then get up, start moving around, it's not as bad. Patients that run get this quite a bit. And like I said, the third and fourth toes are most commonly affected. Number of different treatment options for it is anywhere from orthotics. That usually is a good starting point. A lot of times with the orthotics, I will put a pad in the central part of the orthotic to spread out the bones and so that the nerves have a little bit more room to run through. Anti-inflammatories and physical therapy, they sometimes help, sometimes don't. In this case, therapy, I haven't seen a whole lot of long-term improvement from it. Patients get a lot more improvement with a cortisone injection. Same thing as in the heel. You can only have 3 injections within a 12-month period. That usually works out pretty well. We'll provide patients with relief. Patients come in and they're like, I'm off to Disney next week. Can I get an injection? Sure, no problem. And so usually they make it through Disney and they actually do pretty well. The last two here, dilute injections and also removal of the nerve. These two have the same endpoint, which is numbness of the affected toes. It's just 2 different ways of getting there.